So, without further ado, I am absolutely thrilled to introduce Dr. Dana Bowen-Matthew, Dean of the George Washington University School of Law. Dr. Matthew is a nationally recognized lawyer and legal scholar with 3 decades of industry and academic experience. Dean Matthew is the first woman to lead GW Law. An expert in health equity and public health policy with a passion for public service, Dean Matthew previously served as the University of Virginia's Law School's William L. Matheson and Robert M. Morgenthau Distinguished Professor of Law and the F. Palmer Weber Research Professor of Civil Liberties and Human Rights. She was also a professor of public health sciences at UVA's School of Medicine and served as the director of the Equity Center at UVA, which works to build relationships between the university and its surrounding community to address racial and socioeconomic inequality. Prior to her tenure at UVA, Dean Matthew served as Professor of Law, Vice Dean, and Associate Dean of Academic Affairs at the University of Colorado Law School, and before that as Professor of Law and Medicine at the University of Kentucky College of Law. Dean Matthew has held a number of important positions in the policy world, including as a Robert Wood Johnson Health Policy Fellow in the US Senate, and is a senior advisor in the Office of Civil Rights and in the US Environmental Protection Agency. She's also a non-resident fellow in the Center for Health Policy at the Brookings Institution. A prolific writer, she's the author of a book, Just Medicine, A Cure for Racial Inequality in America's Healthcare, and has authored or co-authored dozens of books and chapters, articles, and that focus largely on healthcare reform, public health law, health disparities, patient protections, and antitrust laws and civil rights. Dean Matthews received a BA in economics from Harvard Radcliffe College, a JD from the University of Virginia School of Law, and a PhD in health and behavioral sciences from the University of Colorado, Denver. We are thrilled to have her here as our keynote speaker. Please join me in welcoming Dean Matthew. Thank you.
Thank you. Thank you, Polly, very much. I know that in this time of Zoom fatigue, can you hear me? Am I centered? And all of those questions are really annoying, but hopefully I am centered. Someone will wave me off if I'm not. Hopefully my mic is unmuted and someone will let me know if I am not, and I will begin. I'm so grateful to be not only with you for this important conversation today, but that is taking place at the George Washington University, where I've just joined as law school dean, really lets me know I found my people and I found my place. So I'm going to motor through some topics that I know are very complex and deserve much more lingering and much more time, but I know that the conversation is only beginning just now because I'm here with you and I have found you and you have warmly welcomed and invited me. I thank you. Before I begin, I do have to say one very brief thank you to Fitz, because I believe he can hear me. He changed my stars, quite honestly, when I was here in 2015-16 as a Robert Wood Johnson Health Policy Fellow. We went to a lot of very important places with a lot of very important speakers, but the light bulbs came on when I met here at George Washington University, Fitz Mullen and Sarah Rosenbaum. They did a day with us, and I decided that Washington was my home, and little did I know that I'd have the honor of being here with you. So thank you to him, and let this be a continuation of his great inspiration and work. I'm going to share my screen so that you can see my slides, and then I will begin to run them. And please do feel very free to tell me, as my students do, if what I think is happening is actually not happening. But I think now you have my first slide, and I can begin a conversation with you about race, health, and access to higher education. So right out of the gate, I'm going to tell you that what happens to me is I agree to a topic and I agree to a title, and then I do the work of putting it together and wish I had done that before agreeing to the title. If I were titling this today, it would say racism, not race, and indeed structural racism, health, and access to education education, not only higher education. You'll see why, but let me say that already I am being disruptive of my own title and topic for you today. I have no conflicts of interest to disclose, no financial relationships or commercial relationships of relevance. So today I will do three things. I will talk about why, what, how, and perhaps give a few nods to solutions, which I know will be certainly only a beginning of a discussion that will be rich and continue throughout the day. So the why. Why should you be listening to a lawyer in the first place? I heard in the introduction, Polly, that the law school has not been engaged in this discussion. Shame on us. I hope that my arrival as dean will change that. But why should you listen to a lawyer, and why should health professionals and lawyers unite in addressing structural racism and its impact on health? And why now? That's the first part of what I'd like to talk with you about today. Secondly, I'd like to talk a little bit about the theory of structural racism. I think it's a version of structural inequality. Here is where I will probably do only a tad bit of justice, and then focus the remainder of my remarks on the primary portion of this discussion, how structural racism works, and use the object lesson of education, racism, and health. All right, so why? Those of you that understand what Fitz meant when he said he was a civil rights doctor know this case, know it very well. And so I'll do only a brief conversation or a brief introduction to it, just to level set. Simpkins v. Cone is a case that desegregated hospitals. It started with a hospital in North Carolina, it's shown here, the Moses H. Cone Memorial Hospital. But much more importantly than simply desegregating this hospital, not only did this case desegregate 7,160 hospitals, but it is the reason we have a Civil Rights Act of 1964 at all. If it were not for the physicians 2 and dentists 3 and patients that joined to bring this lawsuit, it was a lawsuit that was filed in the Fourth Circuit Court of Appeals in 1963, in which a private hospital spending public funds was challenged for segregation. If it were not for this unity, this joining of law and medicine, we would not have civil rights for our discussion today. We'd have no legal remedy for the structural racism that I'll talk about today. Indeed, racism and health are intimately intertwined, not only in the solution side, as with the Simpkins case, but also in the making. Racism plagues, discrimination plagues healthcare. That is a different talk, but for both of those reasons, structural racism is a topic that is, I believe, essential to the appropriate practice, the excellent practice of healthcare and health education. Why now? We have a case study exemplifying my assertion. This is the data. These are the data, rather, from October 15th, 2020, the number of cases, the number of deaths, and we know that these cases, these deaths are highly racialized. This is the object lesson. The object lesson is present, it's front, it's center. Our attention is riveted, and the conversation has been brought to a head. Now, make no mistake about it. The inequality, the racial stratification that we are seeing in the COVID-19 pandemic is not new. It was entirely predictable, and it's because of structural racism that that is true. But the moment is now when we see that if you are American Indian, you are 5.3 times more likely than whites to be hospitalized. If you are African American, you are 4.7 times more likely than whites to be hospitalized. And if you are African American, sadly, this pandemic has 2 times more likely, more than 2 times more likelihood of killing you than if you're white.
Hey, Matthew, I think the audience is seeing a different view than the presenter view. Could you adjust the slide so that we can see the full slide? Sorry for the interruption.
No, that's quite all right. I appreciate the heads up. Let's see. What do you see right now?
We see your slide, and then on the right it says next slide. So it's actually, we're seeing all your notes and whatnot.
That's not what we want.
Yeah.
Give me a moment. Let me see if I can adjust. I'll stop sharing. I'll run my slideshow from the current slide. And you still see it, don't you?
You need to share the screen again.
Okay. All right, what do you see now?
Yeah, it didn't change.
I'm going to try one more time. I'm unable to get rid of the presenter view. Ah, that might do it. Is that the presenter view still?
Yeah, it hasn't changed.
No. Has it changed now?
Yes, thank you.
Okay. All right, so then the data is very clear about the morbidity and mortality inequities. Why is it that this disproportionality is one that we ignore at our peril? Why is it that structural racism is something that we ignore at our peril? Well, these are early data. This is an early snapshot from June of the hot spots where COVID disproportionality was being felt. We saw it initially in New York, large cities like Chicago, Los Angeles. States where the disproportionality was high were in Louisiana back in June. Understanding this as a non-structural disease made us confused about how to face the problem. Here's just one example. It also was clear to us that structural problems overlooked would give us the wrong answer and the wrong way to address disproportionalities by gender, right? And so one of the things I appreciate most about those professionals, those health professionals who understand structural issues, is that you understand that COVID is not killing men because they smoke more or because they are more susceptible by gender or genetics, but that there are disparities that we should be looking at structurally in employment, in housing, in geographic location. And we wasted quite a bit of time thinking about the disparities by gender incorrectly, simply because we were not thinking structurally in the current health crisis. Secondly, we also wasted time thinking that only minorities would be affected, only large cities would be affected, only those who lived in densely populated settings would be affected. This again is another talk, but I understand those who take a population view, a public health view, and a structural view of the COVID crisis to understand the ubiquity of the threat. Much later, this is a snapshot of the hotspots and how they have progressed across the country and affected people of all persuasions and all stratifications. So what is this thing called structural racism that we must understand, or if we fail to, we will not understand or appreciate the ubiquity of the threat to us of death and disease? Well, this audience knows what health equity is, the other end of the spectrum. You know that equity is the opportunity for everyone to be as healthy as possible. You know that it is achieved by eliminating unjust, unfair, and avoidable disparities. You know then, in summary, that inequality is the greatest threat to health equity, and I would suggest the greatest threat to health generally. And we see this in national as well as domestic data. Just quickly, structural inequality is the inverse relation, and its relation to health is shown here as an inverse relationship between what is called the Gini index, that is the measure of the difference in income between the top and bottom quintiles, the top layer or strata of society economically, and the lowest quintile of society economically. That's on the left. And what we see here is a Gini index from the United States to the United Kingdom for all of the OECD nations. It is the right-hand side of this slide that I call your attention to in order to understand the health impact of structural inequality. There you see the OECD nations distributed across a cross-section that shows income inequality on the x-axis, the Gini index, and on the y-axis, an index compiled of 10 different health indicators. And you see that going from better at the lower side of the y-axis to worse health at the top of the y-axis allows us to distribute nations according to their relationship between income inequality and health. And what do you see? In the top right-hand corner, the United States is the outlier. That is, the greater the income inequality in a nation, the worse their composite health outcomes. This is structural inequality generally. How can we define it? Institutions, structures such as family, government, economy, the criminal justice system are organized so that people are stratified or distributed along a continuum of social locations within society, and that continuum affords people the rewards of society based on their location, right? It's a stable system of hierarchy that we call structural inequality. Well, structural racism is a version of, a brand of, a type of structural inequality. Let's start first with the definition of racism, simply straightforward. I borrow this from Kamara Jones. She has done enormously helpful work in defining racism in terms that we all can understand and apply to health. What is it? It is a system. Very important to see it as a system rather than as an individual attitude of bigotry or prejudice. A system of organizing opportunity and assigning resources that does two things, right? First, it unfairly disadvantages people according to a distribution of hierarchy by this thing we call race, by this social construct that we call race. And then secondly, just as defined in structural inequality, structural racism then distributes the rewards, the opportunities, the power of society along this hierarchical continuum. So it's the connection of historic and prior injustice that are stabilized by history, and you'll see in my definition by law as well. The impacts of COVID are an example of, rather, an expression of, an operationalization of that distribution, so that the rewards of society, such as clean water, clean air, access to healthcare, access to food, access to education, all of these rewards and resources are distributed along this hierarchy. That's where we get the structure. And when it's racialized, that's where we get structural racism. So I define structural racism as a system of hierarchical preference that is institutionalized by history and by law, that assigns a hierarchical status of inferior and superior placement in order to distribute the rewards of society. In my next book, forthcoming in the fall, I want to hone in on, and therefore will discuss with you, structural racism and its association with law. They are inextricably linked, as you'll see in the rest of my remarks, and in particular with respect to education, because law is the mechanism by which the hierarchy we've described is established, maintained, and by which the rewards of society that we've described are distributed. Three components of structural racism are legal. First, legalized dehumanization. Second, legalized inequality. And third, unequal protection of law. These are at the foundation of health disparities because they affect all of the social determinants of health in the middle layer of this conceptual framework. Among them, of course, is education, which we'll be focusing on today, and they are connected to health outcomes. At the top of this diagram, I show interpersonal prejudice because it is not that it is irrelevant, it is just not a sufficient component in order to create a system of structural racism. So we could talk more about this, but this is my conceptual framework. I'll take each of those pieces in turn very quickly before I get to education. Legalized dehumanization has been happening historically and currently. This is simply the way in which we treat people of marginalized racial groups, marginalized ethnic groups, as though they were not human, right? So this is a historical tradition in the United States. You see on the left, an etching of a woman being sold by the pound. We are familiar with that, but make no mistake about it, that dehumanization, that commodification of personhood continues today. You see on the right, protesters and activists speaking out about the fact that in 2020, their water is not drinkable. Water is necessary for human life, and yet we have a legalized system in which we still have not afforded potable water. Make no mistake about it, it is not just in Flint, Michigan. There are at least 20 cities. When I worked, as you heard, on the Hill, I was in the office for the senator from Michigan at the time that this water crisis, water contamination crisis broke, and we were able to list 60 cities in which the lead pipe rule had been violated to the extent that it was in Flint, Michigan. And this is an example of contemporary dehumanization that is a foundation of structural racism. Structural racism is legalized inequality. We know this from the Jim Crow era. I won't linger here. We know this from the fight over the constitutional amendment, but we can bring it current. On the left, you see a list of Jim Crow laws, segregation laws by state. It would boggle your mind what we were able to segregate: cemeteries, circuses, why people have to be segregated on death. I'm not sure, but this is an example of the plethora of legalized segregation laws that were in place until the Brown versus Board of Education's decision in 1954 and thereafter. The third component, unequal protection of the law. Even after the Title VI and other civil rights acts were passed, they were not enforced. To this day, we could argue that they are not enforced. That's another talk. Unequal protection of the law. All of this is structural racism. Now let's turn to how it works in the educational context. So first, let me speak for a moment about the link or association between education and health. I'll be referring to a conceptual model by Robert Hahn and Benedict Truman. You see a quote there that suggests that if you lack education, you are not able to be healthy. I hope to convince you of that in very short order. There is a second quote here. It is about the centrality of education and its distinctiveness. It is not like some other governmental benefit. The Supreme Court said in 1982, I will say this is the high watermark of the Supreme Court's view of the importance and centrality of education. We have not returned to this comprehensive a view. But a good education significantly increases one's chances of having good health. A bad education virtually guarantees that one will not have good health. We have copious empirical evidence to confirm this. The scientific record offers multiple reasons for this. And again, this is going to be a drive-by, but this is a model I think that is very helpful in understanding the connection between health and education. Here, there are three major pathways linking education and health outcomes. At the top of the diagram, the psychosocial pathway, which speaks to the health enhancing impact that education has in order to place one within society. It gives one's access to a sense of control, to social standing, to social support. This will in turn affect work, social stress, economics, family stability. This is the first of the three pathways between or that link education and health outcomes. The second is an example of a pathway in the middle, which shows the association between work and economic conditions and health. These are very straightforward. If you are able to get a good education, you can get a better job. If you're able to get a better job, you have better working conditions. You have a better income. These will allow you to access better social determinants of health. That second pathway is fairly straightforward in its association between education and health. The third pathway identifies education's positive influence on health behaviors, health knowledge, health literacy, health behavior, and therefore how one would avail oneself of nutrition, health behaviors, negotiating the healthcare system. So you see that there are multiple pathways linking health and education, and the data that tell us that less education means a shorter life is, as I said, copious. I'm just going to show a few exhibits here. This is a well-known and respected study by Doctors Jennifer Montez, Robert Hummer, and Mark Hayward. They analyzed longitudinal data collected over a 19-year period for over 1 million respondents to the National Longitudinal Mortality Study. Their analysis set out to measure the impact on mortality at various stages of educational completion for different ethnic groups. So you see non-Hispanic whites, non-Hispanic blacks, males, and females. These results are shown to compare the coefficient that describes the odds or risk of death on the x-axis to years of education on the y-axis. The results are not linear, and they're not the same for all educational or social and demographic groups. But there are three results that bear highlighting here for our purposes of understanding structural racism, health, and health education for our discussion. First, educational attainment, though determined early in life, is clearly predictive of your opportunity, your status, and your health throughout the life course. That's number one. Number two, although there is a relatively modest decline in life expectancy after education between the ages of 25 and 64, the touch point that is crucial is a high school education. After receiving a high school diploma, the risk of death declines sharply. This is because a high school diploma is the most basic requirement for decent employment and is prerequisite to higher education. Now, I may not get to solutions because of the time, but let me ask you to pause and think about the import of this finding, of these data on our admissions policies, on our student support policies, on our education policies in higher education. So Dr. Montez and her colleagues conclude through this analysis that aggressively addressing education is a way to aggressively improve health. I would agree. Let me say a few more things about the relationship between education and health outcomes that are particular to the higher education setting. So the myth of higher education is what I think we should concentrate on. The notion that when we get to admit people to higher education, we are looking at a meritocracy. We are looking at admissions on an equal basis. We have to think about the fact that the quality of education on the left is different by race and ethnicity. The experience of education, looking on the right at disciplinarity differences, is different by race. So then, when we look at what COVID revealed, it revealed that educational attainment affected where you lived and therefore your exposure to the virus. It affected where you worked and therefore your exposure to the virus. Place matters, and we have to remember that. These slides are how place has mattered in my life in the South Bronx. This slide exhibits the association between the location of schools and common pollution sources in the South Bronx, which is predominantly Black and brown. So what could we do by way of solutions? Well, we know that healthcare did not see these kinds of scenarios in order to have a revolution. Instead, the quiet revolution that happened through civil rights, as Fitz has described, is what you could duplicate again by the way we educate, by the way we collaborate, by the way we advocate, by the way we admit students, we diversify our workforce, and indeed by the way that we vote.